I am an intensivist. I work in one of the hospital environments where there is mostly technology and high-tech treatments. That's how people usually think about intensive care. But intensive care units are mainly about people. The relationship between all these people in the ICU are so important. The dynamics of the team, but more importantly, the relationship that we build with the patient and the family.
Sono rimasto particolarmente colpito dal pronto intervento ogni volta che avevo necessità, sia a livello fisico che psicologico. Il personale interveniva sempre con molta affabilità, quindi molto gentilmente. Mi sentivo veramente accudito e protetto in ogni momento della giornata. Quindi da questo punto di vista sono rimasto molto soddisfatto. Venivo inoltre informato su quegli aspetti clinici che avrei dovuto subire da quel momento in poi, quindi mi veniva spiegato nei dettagli cosa avrebbero fatto e come lo avrebbero fatto. Al momento del risveglio non avevo ovviamente le idee molto chiare. Stavo vivendo due realtà diverse, una quella vera in rianimazione e un'altra che era quella degli incubi, per cui il primo periodo non avevo ancora capito bene quale delle due era vera. Solamente dopo aver parlato ripetutamente con i medici che mi rassicuravano e mi spiegavano appunto questo fenomeno degli incubi e soprattutto anche dopo aver parlato con mia moglie al telefono, ho capito qual era la vera realtà. Le due realtà erano vissute ambedue dentro il reparto, quindi per me era difficile distinguere. L'ingresso di mia moglie in terapia intensiva è stata una inaspettata e piacevole sorpresa. Non ricordo molto di quel momento, le parole soprattutto, però ricordo benissimo le sensazioni e lo sguardo di mia moglie. La terapia intensiva è un'esperienza sicuramente molto dura e viene vissuta probabilmente in modo diverso da ognuno di noi in base al proprio carattere. Il messaggio che posso mandare è un messaggio di fiducia e di speranza, in quanto dobbiamo totalmente metterci nelle mani del personale sanitario che ha la formazione corretta per gestire soprattutto gli aspetti, oltre che quelli clinici, anche gli aspetti emotivi della persona e quindi psicologici, che sono, secondo me, forse per il paziente e la famiglia gli aspetti più importanti.
You are the spouse, you are the brother, the sister, the parents, the children of an ICU patient, you are a friend. All of you are family members. Of course, we are not going to have the same communication with any of you according to what's the relationship between you and the patient, but we are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
The team was so human and kind. They helped me psychologically every day. I was waiting for the call every day with impatient. So that period was really very hard for my family. The team of ICU became really my family. I felt them closer even than my parents. Every day someone from the team called me and informed me about the situation of my husband and the next steps to do. And I want to say that even if I was far from my husband, I have been always updated about his clinical situation. And when there were very important decisions to make, for example, like tracheotomy, they called me 4-5 times per day. So I want to say thank you. For me, it was a new experience, like for many other people. I have never faced ICU. So after this experience, I changed my life. I changed all points of view. It was a really very hard period, and I was about to lose my husband, but I have never lost hope, and I tried to be strong and rational. I remember my first visit in ICU very well, because it's impossible to forget. It was so emotional. After 64 days, finally, I could see my husband, touch his hands, see his eyes. It was really very difficult to live without him and without personal contact. I don't have enough words to say thank you to the doctors for the possibility that they permitted me to visit him in ICU. Thank you very much. I'd like to say to the future patients and their families that they should trust to the staff of ICU. They are left in the hands of professionals that work tirelessly with passion and love. They are always with the patients. The patients are the primary focus for them. They always gave the warm care and necessary treatment. They never leave alone patients. They are always with them and ready to help them in any moment. The patients are the primary focus for the staff. At the end, I want to say, no matter how ill is the patient, don't give up hope.
Having a loved one in the ICU can be an extremely distressing experience. Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disorientated. So don't forget to take care of yourself. Sometimes you will need to take a break. You don't have to stay with the patient 24 hours a day, and you mustn't feel guilty if you do need to take that break. Don't forget that the ICU team will continue to care for the patient while you're not there, and they will always call you if there is a change in his or her condition.
My name is Silvia. I'm a critical care nurse. I work in an intensive care unit. My work is to assist the doctor and to help them to prepare the patient to get all the medicines and the treatments they need in the ICU. When the family first enters in the intensive care unit, I will receive them and welcome them and present them the room and the patient and explain the condition of the relative. I will be there to receive also their emotions, how they are feeling about it, and explain them what the patient is feeling at the moment, and what we are going to give them for treatment. We will be there in any case to help them to go through these days in the intensive care unit and to perceive and communicate with the patient. We will be there to help him and assist him to the toilet, to the feeding, and to do anything that the patient will not be able to do. But moreover, we also will be there to see how is he feeling, if it's uncomfortable, if it's in pain, to learn to communicate with him all over the stay with all the equipment he will have. We will explain them the things that will happen to him and to his family, and to interact between the doctors and the patient.
The main role of a physiotherapist is the rehabilitation of the patient. With the term rehabilitation, we mean restore the previous situation that the patient had before his or her injury, his or her trauma. And so the patient could have again his or her previously autonomy in the best way it could be possible. A physiotherapist could work inside the intensive care unit, so it is a member of ICU team for all his or her working time, while in other countries the physiotherapist comes to ICU just only for the rehabilitation moment.
Hello, my name is Stefan Schaller. I'm an anesthesiologist and intensivist. As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients. My role is to coordinate the healthcare team to do the diagnosis and the treatment of the patient. To you, as a family members, I have to explain what is going on with your family member in the ICU. I explain to you what we are doing for diagnosis. I tell you the options for treatment and how to treat the patient. Very often, we have to discuss what are the wishes of your relatives, although he's not responsive. Therefore, we discuss together with you what is the best care we could provide for your relative. In the beginning of your ICU treatment, very commonly you are unresponsive. You will be examined by me or a colleague every day. We will make the diagnosis plan and the treatment plan. Later on, when you're waking up again, we are starting to talk with you about the treatment plan as well. While you are unresponsive, we try to discuss the care with your family, or we look at any documentation you provided, how the care should be provided for you.
As a social worker, I'm part of the ICU team. I regularly come on a daily basis to the ICU and talk with the professionals on issues with the families or with the patient. For example, when it's about communication or when there are conflicts, but also when the families have a request so that I can help them to overcome that issue. What I notice is that the families have a really difficult time. They are stressed about their loved one, but they also have, for example, issues for themselves. For example, they have questions, can I take my children into the ICU? Or how can I manage the homework? Or what can I do about financial problems? So I try to help them with that kind of issues. And sometimes they are also asking life questions, because, for example, why is this happening to me or to us? And what's the meaning of this, that he or she is going to have this critical illness? So I try to help them with this kind of issues. My relationship with the patient is to get him or her to learn him better. And I think it's very important to have the values, what is important for the patient, to have them bring into the care that we provide in the ICU. And I think that it is compassionate care, humanizing care, and that is combined with the highest technical and medical treatment that we provide. And in that way, we have excellent care that we can provide in the ICU. And I try to bring my expertise and to have the patient and his meanings and his opinions in front of it.
A special aspect in my daily practice is the communication with the patient and the communication with the families. Communication in ICU is very difficult because clinical situation is very complex and sometimes it's not so easy to explain to families. And in my opinion, the most important thing is to try to keep it very simple, not to spend a lot of technical words, but I just only try to explain the clinical status with simple words. It's very important to try to develop a relationship with the patient and try to keep it quiet, to tell him that the situation is under control. It's very important to maintain a patient calm and confident with the team, because very often the patients are very scared by the environment of the ICU. So it's very, very important to guarantee the comfort of the patient.
We work together as a single team with patients and families, and that's crucial for the recovery of our ICU patients.
Hello everyone, and welcome to another ESICM webinar on the new risk of factors for invasive fungal infections. My name is Laura Galarza. I'm an intensivist at the University General Hospital in Castellón, Spain, and the chair-elect of the ESICM Next Committee. Invasive fungal infections are often found in critical care settings. Patients with compromised immune systems or multiple comorbidities make this infection a real challenge in clinical practice. We also know that patient susceptibility for bacterial and fungal superinfection increases in viraemic pneumonia infections, And reports have shown us that during this COVID-19 pandemic, these infections have been considered an additional contributing factor to patients' mortality. Joining me today to talk about these topics are Dr. Anaïta Rosé and Professor José Artur Paiva. Please send all your questions to these two great speakers through the ESICM TV chat, and they will answer them at the end of both presentations. Our first speakers will be Dr. Anaïta Rosé, and she will be talking about COVID-19 associated pulmonary aspergillosis. Dr. Rosé is an intensivist working in Lille University Hospital in France, and she has coordinated the European Multi-Center Comparative Cohort Study, CAPA, which has evaluated the incidence and risk factors and outcomes of ventilator-associated lower respiratory tract infections, and also invasive pulmonary aspergillosis among intubated patients with COVID-19 or influenza pneumonia. She's also a member of a research team working on ICU-acquired invasive fungal infections and also fungal biomarkers. Thank you, Anaïta, for being here.
Good afternoon, dear colleagues, and let's talk about CAPA. My disclosures, not related to this presentation. So before the pandemic, where did we get with invasive pulmonary aspergillosis, IPA, in the ICU? Over the past 20 years, its incidence has markedly regressed in patients with classical host risk factors, severely immunosuppressed, mainly thanks to prophylaxis, with a shift towards well-established new populations at risk, less immunosuppressed, with COPD, cirrhosis, ARDS. And it's interesting to notice that in neutropenic patients, you will find typical CT scan features, halo, cavities, because invasion of Aspergillus hyphae and necrosis are more significant. But among immunocompetent patients, tissue invasion is less extensive and CT scans lesions are less specific. The ERA-TC case definitions completely exclude non-immunocompromised ICU patients because lung biopsy, which defines proven cases, is rarely performed in our patients, and they don't have the classical host factors, they don't have the classical CT patterns, so we can't classify them in probable or possible cases. ASP-ICU algorithm has been proposed as an alternative to address this issue. Putative IPA combines positive culture of any lower respiratory tract specimen, compatible clinical signs, any infiltrate, and either a host risk factor or, in the absence of a host risk factor, a positive direct microscopy and culture from BAL. BAL here it's very important to distinguish between colonization and invasive disease. If one criterion is not met, the case is classified as Aspergillus colonization. And importantly, this is the only classification that has been validated histologically. Then aspergillosis has been reported to be independently associated with influenza. 14% of non-immunocompromised patients with severe influenza in this large retrospective cohort were diagnosed with aspergillosis. Low dose of corticosteroids in the previous months and SAPS2 were independent risk factors for influenza-associated aspergillosis. It occurred quite early after ICU admission, 3 days median, and was associated with a higher mortality as compared to influenza patients without aspergillosis. A significant rate of positive BAL and serum galactomannan was reported, higher than BAL positive culture, which impacted the possibilities to classify all the cases, which led us to use a modified ASP-ICU algorithm. Entry criterion, host risk factors, and Aspergillus colonization cases disappear, and galactomannan index in BAL and serum are added. To note, bronchoscopy reveals among some patients a specific clinical form, invasive Aspergillus tracheobronchitis, and histology shows ulceration, neutrophilic infiltration, and invasion of Aspergillus hyphae. This tracheobronchitis is associated with higher mortality and a higher serum on BAL galactomannan index, probably because of higher angio-invasion. More recently, an expert panel suggested a specific case definitions for influenza-associated aspergillosis, with a main modification compared to modified ASP-ICU is that BAL is not mandatory in case of cavitating infiltrate to diagnose a probable case, and the positive culture of tracheal aspirate is enough. And they also added the definition of Aspergillus tracheobronchitis, which is defined by bronchoscopic evidence and any positive mycological criteria. Once this history recalled, what have we learned since the start of the pandemic about CAPA? Multiple factors contribute to Aspergillus colonization and invasion in COVID ICU patients. Predisposing factors, immunosuppression, COPD, lytic effects of the virus on respiratory epithelium, resulting in defective mucociliary clearance and further lung and tracheobronchial injury, immune dysregulation and immunomodulating drugs, corticosteroids, IL-6 inhibitors, resulting in increased susceptibility to fungal infections. A new classification for CAPA cases was released out of the blue by European and international mycology societies with an attractive but a bit complicated visual summary. Two major new features, Aspergillus PCR and non-bronchoscopic lavage. The case definitions are designed for critically ill COVID-19 patients. No big change for proven CAPA. Probable CAPA can be defined in addition to previous mycological criteria by 2 positive PCR in serum or 1 in bronchoalveolar lavage, or a combination with a questionable specificity. Tracheobronchitis also appears here, and PCR again is added to mycological criteria. And last, possible CAPA cases are defined with a new kind of respiratory sample, a sort of diluted tracheal aspirate, which technically allows the detection of galactomannan and PCR, but without any validation so far, and probably suggested at a time when intensivists were reluctant to perform BAL in COVID patients for security reasons. I wanted to show you this CT scan from one of our COVID survivors. It illustrates the extensive lung destruction that can be seen with COVID alone or CAPA, but because nodules, cavitations are not specific here. We multiplied BAL, but no trace of Aspergillus, not even 1 PCR. I have summarized here the results of published multi-center large cohorts dealing with CAPA, retrospective and prospective designs, heterogeneous case definitions, and as you can see, CAPA rates range from 5 to 28%, and we are going to discuss further these great variations. Median time from ICU admission to CAPA diagnosis is around 8 days, also with very wide ranges. And the study which reports the shortest time is the one from Bartoletti and colleagues with a systematic screening, including BAL upon admission. So do these numbers reflect the real incidence of the disease? First of all, we have to acknowledge that there is an overlap of included patients. For example, our patients in Lille were included in 3 different studies from the previous table, which of course interferes with our interpretation of the disease burden. The design, prospective or retrospective, surely impacts also the incidence, and there is also a question of standardization of the denominator. Included patients are not all mechanically ventilated, which might underestimate CAPA incidence in studies with less severe patients. Also, 6 studies excluded from the denominator patients who had no or incomplete mycological testing, which may overestimate the reported rates. Also, different classifications are used, from ASP ICU, not suitable to classify all cases, until the last one with a risk of false positive of BAL, galactomannan, and PCR. And systematic screening of patients may also contribute to the mix-up, unlike real-life scenario in which samples are at least collected in patients with compatible clinical history. 3 prospective studies with systematic respiratory screening report higher rates of CAPA, 15 to 28%, and you can see the impact of the classification choice within a same study, with rates ranging from single to double. 3 surprising observations which raise doubts that several CAPA cases might be misclassified. First, mycological profile. Serum galactomannan is rarely positive in less than 20% of cases, which reflects the absence of at least angioinvasion. Probability of survival of CAPA cases decreases with number of positive mycological tests, which indicate different levels of severity associated with reported cases. Second, mortality data. No doubt that CAPA is associated with very high mortality rates, between 50 to 70%. 3 studies have identified CAPA as an independent risk factor for death among COVID ICU patients with different effect size. Putative cases from ASP ICU have the highest odds ratio for mortality. MyCovid is the largest published cohort of mechanically ventilated patients with systematic screening for aspergillosis. It reports 15% prevalence of CAPA and identified proven or probable cases as an independent risk factor for death, together with older age and solid organ transplantation. However, and surprisingly, appropriate antifungal therapy did not improve survival in patients diagnosed with CAPA. Same results here in this cohort from Italy. Some patients diagnosed with CAPA survived without any antifungal treatment, as if reported cases were a sign of gravity, but not an infectious disease to treat. And third, lack of histopathological evidence. In a systematic review of autopsy series, including more than 600 dissidents with COVID, only 8 CAPA were proven. In another small case series of 6 patients, all diagnosed with probable CAPA, none of them were confirmed with guided postmortem biopsy. Finally, almost all the reports we have are coming from Europe and US first waves, when corticosteroid therapy was not yet the standard of care, but location and current practice of immunomodulation may significantly impact incidence of CAPA. So we need a control group. Our team addressed this question in this planned ancillary analysis of the COVAPIT European retrospective cohort, with 36 ICUs involved. The patients who needed mechanical ventilation for at least 2 days were included, and 2 groups were compared: patients with COVID and patients with influenza pneumonia admitted before February 2020, around 500 patients in each group. Overall, the incidence of putative IPA based on ASP-ICU algorithm was low in both groups, and significantly lower in COVID group 2.5% than in influenza group 6%, even after adjusting for non-risk factors for IPA, because COVID patients had less COPD and less immunosuppression as compared to influenza patients. And we found similar results regarding probable IPA based on expert case definition. Median time from intubation to IPA diagnosis was longer for COVID patients, and BAL was less frequently performed, and serum galactomannan was also less frequently positive for COVID patients as compared to influenza patients. In the whole population, putative IPA was associated with significant increase in 28-day mortality and length of ICU stay compared with patients without IPA or colonization. However, our study was retrospective. There was no systematic screening for IPA. If influenza group was not simultaneous, and we choose ASP-ICU algorithm which do not consider galactomannan for case definition. And data, again, came from the first wave and France mostly. Our results may be explained by a higher ability to reach the threshold for tissue and angio invasion for Aspergillus in influenza rather than in COVID, due to more epithelial damage, more tracheobronchitis, more virus-related immune dysregulation, whereas COVID is characterized by early endothelial injury and delayed epithelial damage, less extensive epithelial damage, with maybe an additional effect of immunomodulatory agents. And this pathophysiological hypothesis is supported by more frequent positive serum galactomannan and earlier aspergillosis diagnosing during ICU stay in influenza patients as compared to COVID patients. 4 studies identified independent risk factors for CAPA, and no surprise, host factor for immunosuppression, chronic corticosteroids, age, duration of mechanical ventilation, COPD, and IL-6 inhibitors, or combination of corticosteroids and IL-6 inhibitors, are associated with CAPA in multivariate analyses. Further, this report addresses the impact of negative air pressure in ICU rooms on the risk of IPA. Negative pressure was used during the pandemic to protect caregivers and may be associated with higher risk of Aspergillus colonization and infection. So what practical strategy for diagnosis and treatment at bedside? Last summer, 2 major clinical guidance publications were released, and the suggested strategies look quite different. ECMM-ISHAM recommends systematic screening despite limited sensitivity of serum galactomannan for CAPA diagnosis and weekly tracheal aspirates or non-bronchoscopic lavage to detect possible CAPA that would encourage to perform a BAL and initiate in the meantime antifungal therapy. To be honest, this is not at all our practice. Our local experience is more in line with the recommendations of the task force based on risk stratification and triggered by respiratory deterioration, with the central role of bronchoscopy and BAL in the process associated with targeted serum galactomannan to diagnose putative or probable CAPA and then treat. With this full algorithm published in ICM. There is no data suggesting that antifungal treatment should be different for CAPA or other IPA, first-line voriconazole or isavuconazole, if no azole resistance is suspected, and no recommendation can be made regarding stopping concomitant corticosteroids. The decision has to be individualized. Last, 2 small observational studies evaluate the efficacy of antifungal prophylaxis among COVID-19 patients with IV posaconazole or inhaled amphotericin B, and they show a reduction in the incidence of CAPA, but they have many methodological limitations and no impact on mortality. But at least 2 randomized control studies dealing with prophylaxis are recruiting now. So to conclude, CAPA is reported in 3 to 28% of critically ill COVID-19 patients and has been identified as an independent risk factor for death in several cohorts. Positive aspergillus tests, especially BAL, galactomannan, or PCR, might reflect colonization rather than invasive disease. We need further validation of new case definitions, prospective cohorts with adequate controls, and we need to look for the evolution of IPA incidence with routine use of corticosteroids and also other immunomodulating agents, and also randomized control trials to evaluate the efficacy of prophylactic or preemptive antifungals. Clinical management associate proactive diagnostic strategy based on risk stratification, clinical assessment, and of course bronchoscopy with BAL, and antifungal therapy for patients who deteriorate with reasonably high probability of IPA. Thank you.
Thank you very much, Anaita, for your great presentation. Please remember to send all your questions to both speakers through the ESICM TV chat, and they will answer them after our second presentation. Our second speaker is Professor Jose Artur Paiva, and he will be talking about Candida resistance in the critically ill, what impact on the outcome. Professor Paiva is the director of the Intensive Care Department at Centro Hospitaler Universitario São João in Porto, in Portugal. He's a specialist in intensive care medicine and also in internal medicine. He has also a competency in emergency medicine and in health system management. He's also an associated professor of medicine at the University of Porto and the director of the Portuguese Infection and Antimicrobial Resistance Prevention National Program. He's also the president of the Portuguese Medical Council of Intensive Care and the co-coordinator of the Portuguese Task Force of the Intensive Care Medicine response to COVID-19.
Well, thank you very much for the very kind introduction. It's a pleasure to be here with you. And my task actually is to go from aspergillus to Candida and to address Candida resistance in the critically ill patient and the impact on the outcome. These are my conflict of interests above, and I have an agenda that I propose to you. 6 issues to be addressed during this 20 minutes. The first issue is about the epidemiology and causes of antifungal resistance. You all know we have a changing epidemiology. We go from albicans to non-albicans species of Candida, and in most places nowadays, non-albicans predominate over albican species. This is the CDC Antibiotic Resistance Threats Report 2019 with the US data. You all know also that we have mainly 3 classes of antifungals: the azoles, the polyenes, and the echinocandins, and they act by different ways, and 2 of them in the plasmatic membrane and another one in the cell wall of the fungal cell. And the fact is that you also know that some species of Candida have intrinsic resistance to some antifungal drugs. The main one, Candida krusei, which is intrinsically resistant to fluconazole, but also C. glabrata that displays reduced dose-dependent susceptibility compared with other Candida species. And that primary resistance to fluconazole, although rare, has been described in other species of Candida. In contrast, the echinocandids exhibit potent antifungal activity against most Candida species, but there's one exception, C. parapsilosis, for which higher MICs have been reported. We also know that exposure to azoles promotes azole resistance. We know that azole resistance appears more often if the patient has been on any azole in the last 30 days. And we have ample evidence from several studies, both in intensive care unit patients and in cancer patients, that fluconazole exposure increases the risk of fluconazole-resistant Candida bloodstream infections. There's a landmark report, and the landmark report is 2013 CDC report, in which for the first time fluconazole-resistant Candida is selected as one of the serious threats to human health. After that, we know much more about echinocandins. We know that acquired resistance to fluconazole and to candins is common in C. glabrata isolates from patients exposed to either azoles and to echinocandins. And we also know from several studies on both sides of the Atlantic that C. glabrata also becomes resistant to echinocandins in certain scenarios. And again, recent treatment with an echinocandin is clearly a risk factor for the acquisition of echinocandin resistance. Also, the frequency of C. parapsilosis, a species, as you know, that is known for its reduced susceptibility to echinocandins, was shown to increase after treatment with caspofungin, and a significant association between recent exposure to caspofungin and increased resistance of caspofungin-resistant candidemia was proven in a study coming from Paris. And finally, these very elegant studies from 2015 that shows that prior echinocandin exposure is clearly the main risk factor for C. glabrata echinocandin non-susceptibility and the presence of the FKS mutation that determines this non-susceptibility. So nowadays, to make a long story short, we know a lot about risk factors associated with antifungal resistance. We know that fluconazole resistance is associated with previous fluconazole exposure, with neutropenia, with chronic kidney disease, with critically ill patients, and with the long-term use of underdosed fluconazole. And we know that echinocandin resistance is associated with previous exposure to echinocandins and previous episodes of candidemia, to TPN, to critically ill illness, and to the presence of fluconazole-resistant isolates. And we know more than that. We know that cross-resistance has become a problem. Cross-resistance between azoles has been demonstrated for many Candida species. A high degree of cross-resistance among the echinocandins has also been demonstrated for albicans, glabrata, parapsilosis tropicalis, and cruzi. And although cross-resistance among the azoles and the echinocandins is generally uncommon, reports of MDR, mostly C. glabrata, are beginning to emerge. In fact, in this paper in the CID 2013, echinocandin resistance was associated with cross-resistance to azole antifungals in 36% of the echinocandin-resistant strains. So concerns about MDR, and mostly C. glabrata MDR, have significantly increased. So we now have a new concept, MDR Candida, without a clear standard definition for the concept. The usual definition that we use is calling MDR as an isolate non-susceptible to one or more of two or more classes of drugs, and XDR as an isolate non-susceptible to one or more agents in one or more three drug classes. And as you know, we have the most 4 classes of antifungals. And we also know that most MDR Candida infections involve isolates belonging to species with intrinsic resistance. For instance, echinocandin resistance in C. glabrata and C. cruzi, or infections with C. guillermondi or C. auris, which is intrinsically multi-drug resistant. So most of our problems deciding therapy come, in my opinion, from 3 species: Candida glabrata, because many C. glabrata strains are resistant to fluconazole, and this resistance is fairly constant over the last 20 years. We have cross-resistant to other azoles, and we often have co-resistant to echinocandins, and C. parapsilosis that has a unique intrinsic resistance to echinocandins with MIC values for these antifungals that are naturally higher than other common Candida species, but for which species have been found to be increasingly resistant to azoles. And this has come very clear in 2019 CDC report of the antibiotic resistant threats or antimicrobial resistant threats. We now have drug-resistant Candida species as a serious threat, and we have drug-resistant Candida aureus as an urgent threat. Candida aureus is clearly unique. It's a multi-drug resistant, exhibiting the resistance to fluconazole most of the times, 93% in this paper, and variable susceptibility to other azoles, amphotericin in 35% and echinocandins in 7%. So almost half of the C. aureus isolates are MDR, and they show resistance to 2 or more classes of antifungals in almost 50% of times. And when you try to collect studies reporting C. aureus, you see that the balance between resistance among different antifungals is not totally consistent. And when you take reports from India, you can find even Candin resistance, because actually C. aureus collects many resistance mechanisms for antifungals. And which are these mechanisms? Well, it's a long story, and I'll try not to bore you too much with it. For azole resistance, we have 3 different mechanisms, but the one that predominates is clearly efflux pumps that pumps out the drug out of the cell. For fluconazole resistance, it's very funny because apart from having interspecies and interspecies quorum sensing interaction, we have found that Pseudomonas aeruginosa quorum sensing molecules may confirm protection to neighboring yeasts against azoles, in turn strengthening their coexistence in hostile polymicrobial infection sites. So this means inter-kingdom quorum sensing. For amphotericin B, for which resistance is rare despite 50 years of clinical use as monotherapy, resistant mechanisms are also threefold, but mainly alterations in the composition of the sterols and phospholipids of the membrane. And finally, for echinocandins, their resistance has only been convincingly linked to one molecular mechanism, namely mutation in 2 hotspot regions of the target gene FKS1, and in the special case of C. glabrata in FKS1 and FKS2. The general rule being that FKS1 and 2 hotspot alterations affect all the 3 echinocandins. And for this problem of echinocandin resistance, there's also this adaptive response that the fungal cell can create when exposed to echinocandin, for which these drug-tolerant cells do not induce immediate therapeutic failure, but they can develop a higher level resistance in time by forming stable FKS mutations. The good news is, however, that discontinuation of echinocandin and azole treatment leads to disappearance of FKS alteration, but not, mind you, of azole resistant in Candida glabrata. So this means that a more restricted use of candins, namely through antifungal stewardship, may limit the development of resistance to echinocandins. So Please bear in mind that microbiological resistance and clinical resistance in fungal infections are rather different. There is indeed clinical resistance referring to the persistence of fungal infection despite treatment with adequate therapy. So when your antifungal treatment fails, you may think it's because of a microbial resistance, but it may just be the underlying immunosuppressed condition of the patient, or it may be the non-removal of some prosthetic material, or it may be a wrong pharmacokinetic, wrong TDM, wrong level of the antifungal drug. It may be dissemination of the infection to some sanctuaries, and it may also be the existence of biofilms, which also represent a difficulty in antifungal treatment. And as you know, amphotericin B and echinocandins seem to be much more effective than azoles in biofilm associated fungal infections. So, but what is the link between resistance and outcome? Well, we know that, or it seems to have some evidence that clinical outcome seems to be significantly poorer for patients infected with Candida isolates resistant to fluconazole and voriconazole compared with those that are susceptible. And we have also evidence that Sigillobrata infection caused by echinocandin-resistant species has a poorer clinical outcome than susceptible species. But the real link between Candida phenotype and invasive candidiasis prognosis is still very much blurred. When you pick 4 very important landmark phenotypical characteristics like the species, the susceptibility profile, the biofilm formation, and the glycanic derivatives profile, little is known about how they impact in a good selection of antifungal drugs. But we know that East manoglycoconjugates, namely the balance between beta and alpha oligomonocytes, is instrumental for the fungal cell wall in terms of their plasticity, their structure, their biofilm formation, and their adhesion. And a sub-analysis of the Amercan 2 study shows that East phenotypes with monocyte score inferior or equal to 3 were significantly associated with reduced susceptibility, and that a high expression of beta oligomonocyte tended to be associated with a poorer 28-day outcome. How do we treat MDR Candida? Well, this will be my opinion about how I deal with the situation, taking into account the in vitro susceptibility of Candida species. I have an algorithm with 5 questions. Is the patient hemodynamically unstable? Is there previous use of an azole? Is there an high prevalence or colonization in the patient by Sigillobrata? Is the infection associated with biofilm? And if I answer yes to one of these questions, then I do not use an azole. Only a yes, one yes question is enough to go to the other arm and select an echinocandin. And the doubt comes when I have a patient colonized with a C. parapsilosis, or I work in an environment with a high prevalence of C. parapsilosis, where susceptibility testing is very important and amphotericin B may be needed. So this is my algorithm for empiric treatment. Treatment for MDR infection is clearly a problem. If resistance to azoles and candidas exists, you have to use liposomal ampho-B combined with an extensive search for undrained or unremoved foci of infection. Experimental animal data suggests that some less critical FKS mutation may be associated with response to higher dose of antifungal therapy, namely echinocandins. Data regarding combination of antifungal agents is unconclusive, so we do not have recommendation. And finally, we know of some drugs like FK506 or cyclosporin A that may be able to inhibit efflux pumps and therefore regain susceptibility to azoles by the fungal wall. And of course, we have to explore new antifungals. This is very, very important. And these new antifungals have to respond to three main issues that I show here. Candida auris is a problem, and as you know, COVID-19 has uncovered a lot of these infections. Initial treatment with echinocandin is recommended. However, although CAPA function is usually effective against biofilms formed by other Candida species, it is not very much effective against C. auris biofilm. If the patient is unresponsive to the echinocandin and fungemia is persistent for more than 5 days, then you may try liposomal amphotericin B. And it seems that newer azoles like isovuconazole has an excellent in vitro activity against C. auris. Finally, how do I tackle antifungal resistance? Well, I think that we need to address a few points very, very quickly. We need to adhere to infection prevention and control guidelines very closely. We need to improve fungal diagnosis. This is very important, using a good balance between cultural tests, going to the species plus non-cultural tests, and making viable short turnaround times for diagnosis. We need to prescribe antifungal drugs only when needed to decrease MDR Candida. And when we prescribe them, we need to use adequate doses and dose duration. And if we are lucky enough for that, TDM is very, very important, namely for azole use. We need to test for antifungal resistance in patients with invasive disease, mainly in that one caused by C. glabrata, C. parapsilosis, and C. auris, or whenever the patient is not improving to our first-line regimen. We need to remove devices as soon as they are not necessary. We need to implement antifungal stewardship programs. We know that as much as 30 to 50% of antifungal prescriptions may be optimized or are at all inappropriate. And finally, we need to conduct surveillance to promote awareness of resistance pathogens so that we may improve empirical treatment and making everyone aware of the data of their own institution. Guidelines for susceptibility testings are, I would say, very much consensus nowadays in terms of testing for azole susceptibility, which is recommended for all bloodstream and other clinical relevant Candida isolates, and also nowadays for echinocandin susceptibility in a smaller group of patients. Finally, my take-home messages would be there is sustained azole resistance in the last 20 years and a growing problem of echinocandin resistance. There's also a growing expression of cross-resistance and of MDR Candida, which is nowadays a threat, namely in C. glabrata, cruzi, parapsilosis, and auris. The mechanisms are rather well understood nowadays and a bit different from antifungal class to antifungal class. We have to consider that when our treatment fails, it may be clinical resistance and not actually microbiological resistance. But Candida resistance seems to be clearly associated with a worse outcome. I've tried to convince you that a 5 questions algorithm to decide your best empirical antifungal treatment may be used. And finally, I try to give you a receipt to tackle antifungal resistance, combining expeditious fungal diagnosis, adequate drug and dose selection, the use of susceptibility tests and of TDM, and the implementation of antifungal stewardship, fungal surveillance, and most of all, good ICP practices. Thank you very much.
Thank you very much, Professor Paiva, for your great presentation. So now we come to our question time. We have many questions on the chat, but please keep asking them. And the first one is to Dr. Anahita. So in the real life, in which age group CAPA was common among COVID patients, according to your experience? What's the age range of these patients?
The age?
Age, yeah.
Oh, yes. The age is older. At least in two studies, the older age was associated with CAPA. So above 60-year-old.
But it's your experience in your center too.
Also,
yeah.
Totally, yes.
Okay, and Professor Paiva, do you think that high doses of fluconazole, maybe 1800 milligrams per day or even more, could protect against resistance development?
Thank you for the question. I think it's very important to use adequate doses of fluconazole, and it's probably the antifungal drug that I feel is very often underdosed. So we have to use 12 milligrams per kilo per day as a low dose on first day, and 6 milligrams per kilo every day 2 from then on. So this is very important. And of course, I think it would be very important to have a therapeutic drug monitoring for azoles. This is especially important for voriconazole, in which the risk of being under the 1.5 or 1.2 and above the 5.5, meaning that there's a window that guarantees the good balance between effectiveness and absence of toxicity. And for voriconazole and for fluconazole, as you know, we have several studies since the DALI study that shows there's a huge variability in critically ill patients regarding the concentration in serum, and even more when we think about the actual focus of the infection. So to make a long story short, using TDM is the right way to go, and we have tried to publish we have published a consensus statement led by the Brisbane Centre about what we consider good concentrations for azoles and echinocandins. And if you do not have the TDM, you really have to be careful when you use voriconazole, because your concentrations may be very everywhere. And for fluconazole, don't forget of the loading dose 12 milligrams per kilo and then 6 milligrams per kilo from then on.
Thank you. Dr. Anahita, next question is for you. If a patient develops aspergillosis in his or her BAL, but is otherwise in a very good condition, maybe it's extubated, has normal blood gases, it's stable, should he or she receive treatment for CAPA?
Excellent question. It happens often. For me, yesterday, I have a patient in my ICU which was extubated yesterday. He's totally fine with COVID, and the results of the BAL came after. It was not a culture. It was just a PCR. So I think we have to individualize what kind of positive tests are exposed here, because it's not the same specificity for CAPA diagnosis if you are talking about microscopic examination with IFI in BAL, culture, galactomannan, or PCR. If it's just a galactomannan or a PCR and nothing else is wrong with the patient, I think it's not urgent and mandatory to treat. If it's something with a higher specificity, microscopic examination, culture, and maybe some specific patterns on CT scan, then you should maybe think twice and maybe treat. But the clinical stability is, I think, a major point to think twice before treating.
Thank you, Anita. Professor Paiva, what do you think of high doses of fluconazole and changes in AKG? Are you concerned about some cardiological changes in these patients?
What do I think about high doses of fluconazole?
Yeah, and the changes in the electrocardiogram that we can see.
Yeah,
or have been described.
I mean, I'm not recommending high doses. I'm recommending the right doses of fluconazole, which is 12 milligrams per kilo per day first day, and then 6 milligrams per kilo. But your questions reminds a very important warning, which is the fact that most of the azoles have huge drug-drug interactions. So I would be particularly careful using azoles with in patients that have that are using drugs that go also through the cytochrome P450 metabolism, and for us intensivists, these patients occur very often because we treat a lot of patients that are under immunosuppressants, transplant patients, and this kind of patients with neurocritical disease that are under anti-epileptic drugs, and patients with are paretic in terms of their bowel and their digestive tract, in which we try to use also drugs to promote peristalsis, and they may also interact through the same metabolism. So yes, remember that azoles are very important, significant and frequent drug-drug interactions, and that, for instance, the echinocandins have less drug-drug interactions, and if you think of the three different echinocandins, maybe anidilafangin, because of their very specific metabolism, is the one with the least drug-drug interaction. So you have to decide on the basis of your patient. That's the beauty of it. I mean, that's why we need doctors, and we don't have robots in the ICUs yet. We will get there, but we are still needed, and you have to discuss each patient on their own.
Thank you, Professor Paiva. And I'm going to send you a question for both of you. Should we isolate these patients, CAPA patients, and also patients with maybe MDR candidemia, because not all Candida patients, but some of them?
Okay, so I begin for CAPA. We don't isolate patients with Aspergillus colonization or infection. And you see maybe my slide about air pressure, negative air pressure in the ICU. And maybe, in fact, we, with our experience to protect caregivers, we have maybe more exposed patients to Aspergillus. So I think there is no need for a specific air pressuring in the ICU for these patients. And if yes, maybe slightly positive, and no need for isolation for these patients.
Well, I globally agree, yes, but my message would be, when we speak about isolation, we tend to think about four walls, a ceiling and a floor with a door. But that's just one kind of isolation, which is not the most important isolation. When we ICP persons use the concept isolation, it means the way I equip myself to approach the patient. That's what isolation means. And you may have the patient in reverse isolation, meaning inside a room, and be totally bad and wrong in the way you isolate, you promote your isolation, your relation in terms of the patient, the way you use your personal protective equipment. So the one thing that I feel is most important actually is, depending on the site that you have the MDR Candida, or depending on the site that you have the XDR Acinetobacter, or depending on the site you have your MRSA, you have to define the way that you equip yourself and you deal with the patient. And if the patient is able to go around and go to the bath in the ICU, how you disinfect the handles of the doors and the things that the patient touches. Taking into account what I've been discussing with you, a special case is C. auris, okay? Because C. auris puts a lot of problems in terms of the use of disinfection and biocides, because it's much more resistant than the other forms of MDRs and XDRs, and we often deal with concepts that are much closer to Clostridium difficile somehow than to the use of normal biocides. So apart from C. auris, I totally agree with Anaïta Rosé, and I think that whenever a nurse or a doctor says isolation, I try to remind them that isolation is a behavior, not a room.
Yeah, I completely agree with you. One question for you, Anaïta. In the patients with COVID in the ICU for maybe several weeks or even months, and maybe some studies had reported that he had previous infections. So do you routinely send cultures or serology for possible fungal infections, or do you wait for the patient to clinically deteriorate?
Yes, in our experience, the prevalence of CAPA was not so important that we had to organize systematic screening. Maybe in some other ICUs it's not the same, and I think there is important regional and geographical variations in this issue. But in my practice, we do not screen systematically patients, even if they are here for several weeks or months. But if there is a clinical deterioration or a new lesion on CT scan that we are not explaining, then we will do a bronchoscopy and BAL.
Thank you. And one last question for Professor Paiva, or both of you. How about the duration of the treatment? Should we adapt them to the patient, how he or she is doing, or depends on the species of the fungus? What do you think?
Well, I'll start now, just to be a gentleman. So for Candida, as you know, there's a clear guideline for a candidemia. So you take the first blood culture that is negative after the positive one, and you count 14 days after that first negative blood culture. And if the patient is improving, then you stop after this 14 days. For invasive candidiasis, it's rather difficult because there's no evidence whatsoever. What I can tell is that most centers emulate or take the same formula that is used for candidemia, which for me is rather long. I think that we should use antifungals for a smaller duration of time than we do now. There's a huge problem with intra-abdominal candidiasis, which as you know, is long-standing infection that usually goes to theater, like secondary or usually tertiary peritonitis that goes to theater or to TC, radiological guided drainage. And we often have to prolong antifungal treatment for a long time. But so I would say that try to do it the least that you can. But for candidemia, the rule is 14 days after your first negative blood culture. And that's why it is very important, in my opinion, to have earlier second blood culture. So if you have the diagnosis of candidemia, for instance, in my center, 48 hours later, we take the first sample, the first repeat blood culture, because if you are lucky enough to be negative, then we will decrease the global number of days under antifungal. As for antibacterials, underdosing and long-term therapy is the main driver of resistance. I'm glad that I'm not the one to respond to the aspergillosis duration of treatment.
Yeah.
Okay, for the aspergillosis, in fact, we don't know which patients will benefit from just the initiation of the treatment. So the duration, I cannot tell. If we are sure, 6 weeks, maybe more, but I can't tell.
Thank you very much, both of you, for being so sincere. And also, we've run out of time. We've more than 2 minutes. We should have finished yet. And thank you very much both for being here. It was lovely seeing you. And I hope our audience had enjoyed as much as I had that. And thank you very much. Have a lovely, lovely evening.
Thank you.
Thank you, Laura.
Bye.
Bye-bye.